So let's start. A very good afternoon to all of you. It is with a great pleasure that we extend a warm welcome of each and every faculty member, scientist, researcher, research scholar present in this 5 days online international faculty development program on bridging research and innovation in biomedical science and engineering, organized by School of Allied Health Science, School of Biomedical Science, and the Institute Innovation Council of Galgotia University. We are highly privileged to have assembled and assembling the distinguished panel of speakers and experts who are sharing their expertise, experiences, and latest innovation and advancement in the biomedical engineering and biomedical science field. So this program will present a unique opportunity to all the participants to learn from the keynote speakers, and you can also exchange your idea with our experts and each other. So as a participant, your active engagement and enthusiasm will play a crucial role in making this program successful. And we encourage you to actively participate in all sessions, ask your query, and share your insight and experience with us. So I would be very happy to invite uh, Dean Student Welfare, A.K. Jain sir, to kindly introduce our speaker. A.K. Jain sir, over to you. Sir, you are muted. Jain sir, you are muted.
Hello, you mean me or?
Okay.
Yeah, okay. So
Yes,
Gaurav,
sir.
now audible?
Yes, sir. Yes, sir. Yes, sir.
Okay. Thank you, Dr. Gaurav, to give me this opportunity to introduce the very important speaker of this session. Stephen Rachel, a visionary leader in the field of physiotherapy and osteopathy, is with us for this session. His expertise in the facial therapies and manual therapies techniques through his innovative research, clinical practice, and education initiatives. He completed his education journey through diploma in physiotherapy from University School of Physiotherapy at University of Valencia. After that, he completed his master's in osteopathy in holistic healthcare from University of Madrid School of Osteopathy. In his career, Rachel demonstrated keen interest in facial therapies, recognizing the crucial role of facial systems in maintaining optimum health and well-being. As an academician, he authored number of articles, books, which include racial facial coordinate system, diagnosis and treatment of facial system. His publication are very important resources for healthcare professional and academic purpose. As an entrepreneur, Rachel is empowering of Rachel Osteopathy and Physiotherapy Clinic in Valencia, Spain, where he produces professionals, personalized care, and innovative treatment to his patients. Additionally, he has pioneered the development of Rachel manual therapy tools and pelvic floor tools for his patients. He has conducted workshops and lectures on the topic ranging from facial therapies to cupping, leaving a lasting impression in the healthcare professionals worldwide. And we are eager to listen Mr. Rachel through his versatile experience in his domain. Over to you, Doctor. Thank you very much.
Thank you so much, sir. So it is our honor and privilege to invite our esteemed guest speaker, Professor Richali. Over to you, sir.
Hello, good morning. You can hear me?
Yes, sir. Yes, sir.
Good morning.
You can see my presentation?
Yes, sir.
Okay, you can see if I change the image, it works?
Yes, sir. Yes, sir.
Okay, perfect. So I'm going to start. I'm so sorry that my camera is not working. I have tried two different, but something is not working with this program. So you will only hear my voice in my presentation. I'm so sorry. Next time, maybe you will see.
No problem, Stephen. It's okay. Yeah.
Okay, thank you so much to invite me and to let me explain you a little bit about fascia. I hope you will like it. So first of all, for me, it's very important that we understand that the diagnostic or the assessment will be the most important thing in physical therapy. If you don't have a good assessment, all your therapies, even if you are the best physical therapist in the world, you can make a lot of mistakes or your treatment can be so successful as it could be. I have shared this image here with you. That's how to properly assemble furnitures. Because for me, a furniture has some similarities with a human patient. Because if you have a furniture which is not assembled, you have a plan how to fix all the parts. And if you don't follow the right way how to assemble all the pieces, at the end, well, maybe you have too much pieces which are not assembled or the furniture is not finished. So you have to disbuild everything again and start from the beginning. So in physical therapy and with the human body, if you want to treat it well, you have to know exactly what you have to treat, in which direction you have to treat, in which order you have to treat. And if you do it in the wrong way, your success will not so great as if you do it in the right way. So for me, it's very important to have a plan how to treat your patient, and it has to be in good order. Also, you need the best tools to make the treatment and the assessment. If you choose the wrong tool or you do the technique not in the correct order or intensity, you will also have problems. So let's see why a global diagnostic is so important. And please remember this image here of the skin, which I have put here in the background of the title, because the structure of the skin, all these thinny triangles or geometric figures, you have to remember them later for my explanation, because skin for me is very, very important in the assessment of the human body. So let's talk about the injury mechanisms. We have traumatic ones, we have mechanical ones, and we have also biochemicals ones. All of them could be very important. We have to ask our patient about many things to be quite sure which is the main problem of it, because we can have an accident, and then it's quite sure that the accident was the problem that produced my pathology, but I can have days before a mechanical overload, and I can have a bad nutrition, and all this can increase the pathology that my patient has. So even if we really know or think that we know that the cause of the pain is in traumatic accident or on mechanical overload, we have to research a little bit more and think that there could be many background things that can increase or chronify the pathology of our patient. Normally, all the systems that in physical therapy will be diagnostic by the physical therapist is normally more the musculoskeletal system, the blood supply, the nerve system, but normally fascia system is not integrated in the assessment of the human body. And if you really understand what is connective tissue, how its name says, interconnects absolutely everything in the body. Nothing is outside of the body of connective tissue. All the systems are integrated in the fascial system, so nothing escapes of the influence of the fascial system. So why we don't analyze the fascial system when we are treating our patient? So this will be very, very important. So we have to analyze all the background of our patient. We have to make an examination of our patient. And then we have to look also for the mobility of our patient. This is very important. But to understand what we are looking for when we make an assessment of the fascia system, we have to understand a little bit the fascia system. Fascia system wraps us completely from the outside to the inside, interconnect everything. So we have different layers. We have the skin, the superficial fascia, the deep fascia, and all they are connected and then connected with the musculoskeletal system and with all the organs. And we have two components. We have a component which is elastic, like a bungee, and we have another part inside, which is the collagen, which is not elastic, which gives the structure. And then we have the ground substance, which is in fluid, which is all bedded inside and allows the sliding and maintain the distance between the different fibers. So we have an elastic component and we have a force component, and both of them have to be in equal or in balance, because depending of what we want of the structure of connective tissue, if we want force transmission, we need more collagen. If we need more mobility, we need more elastin, like in joint capsule. And force transmission, very strong, will be like a tendon where all the fibers are more collagen and very less elastin. So depending of how is the composition between elastin and collagen, we have different kinds of connective tissue, but all or everything is connective tissue. This is in schematic view of how is the fascia system. We have the outside, we have the skin with the superficial fascia, then the deep fascia, and then we have the different muscles. But if you see, all is interconnected and all is wrapped and all is surrounded by the fascia system. So any kind of mechanical input in the outside will be transmitted through the connective tissue to all the parts of the body. So real fascia system allows us to understand how is the body working, all the connections and all the influence to all the other systems which are integrated in the fascia system. The collagen fibers normally are presented in a wave structure, interconnected or overwrapped by elastin. So we can stretch collagen by defolding or making the wave lower. And elastin will bring the collagen fibers to its own structure again. So collagen is unable to be stretched but by the way that is in a wave form, it could be mobilized or can be deformed. We have to imagine also this connective tissue like in spider web. The spider web, the structure, many fibers in all directions, and depending on how is the structure of the spider web, we have more possibilities to mobilize the structure of the spider web in one direction or depending on in which direction are these fibers. So skin and superficial fascia allows us to have deformation. We can fold it, we can defold it, we can make a torsion, but we can stretch the skin and the superficial fascia, which will be very interesting and important in the assessment. We have also a piezoelectric effect that all the structures which are stretched change their polarity of electricity. So the influence of this change of electricity has also a big influence in the skin and can be modified by waves like by mobile phones or other things that can have an influence in the skin. So people who are stressed or exposed to this electromagnetic fields can have also problems in the superficial. The movement of the fascia, well, imagine any kind of structure, and especially the human body, when we are moving in the outside, in the more superficial layer is where we have the real changes of tension. So if we make flexion, we have stretching in the overside and compression on the other side. And if we make extension, we have compression on the higher side and stretching on the other side. So the real changes of tension happens in the superficial, and they are immediately. When we go from the superficial to deeper layers, then we have changes from compression to stretching and opposite in the flexion. So, but the real changes and the strongest changes will be in the superficial in one side or the other side. And in the body, nothing happens without information. Without information in the body, nothing happens. So there must be something that gives the brain the information. The brain analyzes this information and then gives a response. So the body really needs information, and the information will come from the outside of the body, from the superficial, from the skin and superficial fascia, because exactly there we have 80% of all the nerve receptors in the body. So in real, our proprioception system is the skin and superficial fascia, because there's where the immediately tension changes happens. So the body analyzes these changes and knows exactly, reading the information of the skin, how is the position of the body, and then adapt the muscle contraction and all the other things inside the body. So the real relation is outside gives information to the brain gives information to the muscle gives direction, and obviously the muscles, the tendons, and the joints capsule also gives information to the brain, explaining that everything is happening like the orders which was transmitted by the brain. But the real or the most important information comes from the outside, from the superficial fascia and skin. How I told you, all the ligaments, tendons have also inflammation, but there are secondary information after the information from the outside. So coming back to the skin, skin is not elastic. Skin has only 0.7% of elasticity. So it's like nothing. Skin is very, very stiff in the order that we don't can stretch it. It's flexible. We can make a deformation, but we don't can stretch the tissue. And this is very important because in the superficial, we have said there take place all the changes or the immediately changes of tension. So if we have an elastic skin, this will be disappeared. We will lose information if we have an elastic skin. So we need a very inelastic skin to activate the nerve receptors as quick as possible. So this is why skin has to be so inelastic. Skin obviously can grow, but not immediately. We need a long time stretch effect on the skin that the skin can grow, but if we eat too much, we will get bigger and the skin will adapt. And a nice research that has been taken is that fat people has more elasticity and more immediately explosive force than thin people. And the real difference between big people or fat people and skinny people is they have more skin. So more skin means less initial tension. Less initial tension means that they can adapt better to the movement, because if you are very skinny and you have very low skin, any kind of movement, or maybe also the static posture has an increase of tension. This increase of tension will activate your muscles makes you more stiffer, then don't make you so elastic, and also produce an overload of the muscle. And if the muscle is overloaded, it's not possible to make an explosive force. Different in the fat people, they have less tension in the superficial. They need higher movements to increase to the maximum the tension and to activate to the maximum the muscle. So they are more elastic, and while in a static position, they have less tension, their muscles are more relaxed, and then they are more explosive. Another point that allows to say that the skin is so important is there exist skin tension lines. The skin tension lines are very important because, well, normally they will be used by the surgical when you have to make a cut inside the skin to make a surgery, and the surgeries don't make the cut like they want, because if they make it in the wrong way, the scare don't glue together or make a hypertrophic scare. So to have a nice scare, they have to follow the skin tension lines. And if you see the imagine, you will see that in the thoracic area, you have the skin tension lines in horizontal, and in extremities, there will be longitudinal. So they adapt to the movement, because in the thoracic area, normally you make rotation the whole day, or principally you make rotation. In the extremities, you make flex extension. So if you have a skin tension line or an increase of tension in this direction, this means that in this kind of movement, the skin will more or increase their tension higher or more immediately, which allows to make a more precise activation of all the nerve endings, which are in the skin, and which explains the brain, in which position is the body. So, but how manage the skin, even that it's not elastic, allows us to move us? Because if we imagine that we have a dress on or clothes on which are not elastic, it means that we are not able to move us properly. But the body makes the solution gluing the skin on specific areas to allow that a specific surface has a specific form. And then if we see our body, we will see we have different forms. We have two pectorals. We have not only one, we have two. We have one. We see that our body has a specific form, and this is why we have the skin on specific areas glued. And this makes these quadrants, which allows that each quadrant has his specific mobility, and all the quadrants have to be free to slide over the body in the movement. And if one quadrant is too much fixed or is in a direction anywhere, this will decrease the movement of all the quadrants and increase the tension in the superficial and give them bad information to the nerve receptors, because they will be activated too early or too late, depending on the tension. And this gluing of the skin to the body allows that we have forms like in the pectoral. So the pectoral is in this form. And when we lift up our arm, the pectoral gets flat. And this allows that the borders of this superficial, which is glued on the body, separate itself. And this allows even that we have a not elastic skin, that it can be increase their superficial. In the axilla, we have a very folded skin. We can defold it. And in the flat areas, we have the thing that fat is between different layers, between the superficial fascia and the deep fascia. And if we have very low fat, like in skinny people, the movement between the two layers is very short. So we have a high increase of tension in any movement. But if we have a bigger layer of fat between the two fascial layers, there is more movement, and the increase of tension comes a little bit later. And this allows a later activation of the muscles and be more elastic. This was also studied by research, where they wanted to analyze the movement of the joints by using external markers on the skin, and within video records analyze the movement of the joints. And they see that it don't work, because skin moves differently from the joint. And this is also very important to understand later to analyze how to move the body and to know how the tension was transmitted in the body. Because, like an example, in the hip flexion, the tension of the skin moves up, so the tension comes from down to up. And on the other side, on the back, in the same movement, the skin will go to the knee or to the heel, and will increase the tension on the back side in direction. So depending on how you are moving, the movements will be completely different of the skin. And this is also something that we have to respect later when we are treating our patient. An abduction is the inside where the skin goes down to the knee, and the outside it is coming up. So now analyze the posture that we are normally sitting the whole day. The patients, well, patient or normally population nowadays are sitting a long time. So in the front side, we have a decrease of tension, and on the back side, we have an increase of tension. So skin adapts normally to the necessaries of the body, and this means that the skin in the front side will decrease, and in the back side it will increase. So we have more skin in the back side than the front side. And what happens when we stand up? When we stand up, we will have increase on the front side of tension and a decrease of tension on the back side. So an increase of tension in a lower or less skin in the front side means a high increase in high activation of the muscles. So you increase the muscle tone on the front and decrease the muscle tone on the backside because the skin is relaxed. And how we are working, normally all the people are in front flexion, or nobody works in extension. Normally we work a little bit in flexion and increasing our curves of our spine. So this is also very important to know. And if we do movements or position which are symmetric, well, we have in symmetric shortness or longness in the skin. But if we do asymmetric postures, we have an asymmetric tension in the body, and this will bring us to disinformation in the body. So imagine in the rotation, you will see these quadrants. They some of them, depending on the posture, will increase their tension, and other ones will be compressed. So we have more tension on one side, decompression on the other side, and this is what exactly gives the right or good information to the brain. And depending on how we move, this could be transmitted to the whole body, and this allows us really to understand how tension is transmitted to the body, because other concepts of fascia, like anatomic strains, where you have muscle change, where they analyze the tension or transmission of forces in the inside, don't allow us really to make this kind of movements, because we have front lines, we have lateral lines, we have cross lines, but the interaction of all the lines in very complicated movements could not be explained by internal lines like that. But in the skin or in the superficial, because it covers us completely from the head to the feet and in all direction, any kind of movement can be transmitted by the surface in any direction. So also imagine when we make a flexion and we have an increase of tension in one specific point. If we want to reduce this tension, we have to approximate the skin to this point to decrease the tension in this specific point. And this means that our strokes or our movements or our manipulation of the skin don't have to be only in one direction. It has to be specific in the direction in which we decrease the tension. So it means in this specific case that we have to push down the skin from the higher part and from the lower part just to the middle to decrease the tension. If we have an excess of compression, we have to remove the skin from this point to decrease the compression in the extension, for example. So it's very important to know how the skin is moving, which part is compressed, which part is stretched, to know exactly in which direction we have to move the skin. And very nice example is if we have a pen on and we make a knee flexion, we feel too much pressure on the knee, we have to lift up and from the higher part to decrease the tension there on the knee. And the back side, we will put our pen down and up from the knee on. So this is very important to know. So if we have in our body, in the superficial, in one of the quadrants, one specific aberration which don't allow us to move properly this quadrant, this also don't allow that the other quadrants be so mobile because they have a very reduced mobility, and the summary of all the mobilities of all the quadrants allows the right mobility. So if one is restricted, will affect the other ones, and depending in which direction we are moving, it can increase one specific area. Then this specific area which is overload or have an excess of tension will activate too much the muscle. This will produce a contraction and a reduction of mobility. And if we force this area, we will have an overload, and this will produce our pathology. But as I told you in the beginning, we can have an accident, a traumatic one. We fall to the floor, or with the motor bicycle, we have a problem in the shoulder. But we don't know that we have this restriction in our abdominal part month before doing another exercise or what else, but which already don't affect our shoulder. But after the accident and with this tension which comes from the abdominal area, maybe it could be both together too much to have a good recovery of this injury. So we have to analyze the whole body, even if we know exactly what happened or what produces the pain in the shoulder, because there can be many other factors which can increase the pathology or be the real origin of the pathology. So we can have different points, and the summary of different points produce a pathology. Only one maybe not, but the summary of difference can have. We can have from front and back side. We can have from lower parts to higher parts. We can have an influence only from front side, from back side. This is very complicated, but if we make a good assessment, we will be able to know it. So what we really are going to do is to see where the aberration, where the restriction of mobility of the skin. We can make a pinching of all the skin of the body or with a cup to see where the aberration. So we're going to analyze the mobility of the skin using the movement of the patient. We have all these quadrants. All of them have to be mobile, and the patient is able to explain us when he's moving, where he feels the tension, and knowing where are the asymmetries of tension, we can find out which is a disturbing point and where we have to start our movement. So we are using the movement of the patient in standing, sitting, and lying position, and prone and supine. So many different positions, many different movements, and the summary of all this movement will allow us to know exactly where are the tension, because the patient is able to, when he's making a moving, to say us if you feel more or less tension in one specific area. This allows us to know exactly which is the starting point. Normally after 2 minutes of treatment of the starting point, we have a release of this point, and we will see also the influence of this first point of the other findings that we have, and then on. This gives us the right pathway how we have to treat our patient. So all the different movements have different points that we can be positive. And if we have the same point in different movements, we are quite sure that we have a problem there in this region. Skin is also very significant in giving us information, not also on the tension. Skin in the evolution, when the body is in its formation and doing the formation, then the skin has a direct relationship. The epidermis has a direct influence or relationship with the nerve system. The mesoderma has a direct influence with all the muscles, and the endoderma has a different direct influence with the organs. So if we have in the skin one specific alteration, we can read it and make the relationship with the nerve system, with the muscle systems, or with the organs, because that's like a map which is reflected all the point. And if we have no specific findings in asymmetry of tension, but we have alteration of sensibility in the different areas of the skin, we can also know maybe it could be a problem of the organs or muscles. And they will produce an ischemic reflex, which produce again an alteration of the mobility of the skin, and this with the time can produce also a mechanical problem. So we can have just a reflexed pain in one area without restriction of movement, and this with the time can produce a restriction of movement because this ischemic reflex of the skin, and this will alterate the mobility in the surface. Knowing all this, we can have all this information. We will have to understand the system that we're going to work from the distal to proximal, because normally the fascia tissues, which are more stronger, are more in the lower extremities, especially like fascia lata. And so from distal to proximal, then from front to back, because on the front side we are normally shorter than in the back side. It coincides with different maneuvers, which means different position, different movements give the same tension, the same point. That will clarify that this point will be more important than other ones. If we have in stiff area, the stiff area, even if it's not tension, is more important than a tension area. Then we have the tightest point, and also all the postural matter that can justify the point. Then how to register all the data that we will have. We have 3 crosses. One is for the lower extremities, one is for the trunk, one is for the higher extremities. And we have front, rear, left, and right. And there we will put our points. So it will clarify it by very easy look if we have more problems on the right side, on the left side. And to treat our patient, we will go ever from front to rear and from down to up. So we have the real pathway. We are only going to treat one point, see if it has release, and if it has release, then we check the second point in importance. If it's still there, we treat it. If it's not more there, we don't treat this point. So we are quite sure that we're going the right way. We see then we remove all the asymmetries in the body, and then at the end we ask if our patients still have neck pain or shoulder pain, the reason why he comes to our clinic. And if there's still there a problem, okay, then we are quite sure that the problem is only there in the shoulder. Maybe it's a tendon or something else is broken there. So then we are quite sure that the problem is only there, but it has no influence on the rest on the body. And only so we are quite sure that we have the right treatment in the right point and for the right time. Now, to resolve all these problems, it will be very interesting to use therapy tools, because our hands are limited in force and in ability, and we can increase the ability, the sensibility also, and the force of our hands using therapy tools. We have more power in transmission, decrease the effort, greater resistance. And for the physical therapists during the treatment, we have better mechanisms, increase the speed in inertia, the heat, better grip, better force vectors, because the form of the tool allows us to have force vectors in different directions. Normally our fingers are flat, so there are only 2 vectors, compression and a little bit of tension. So depending on the form of the therapy tool, we can increase this force vectors and adapt us better to the necessities of the treatment. And also we increase the sensibility and the comfort of the physical therapist. All the tools which are stiff transmit better information than tools which are not stiff, which are more like a bungee or something like that, because it's much stiffer, it's much better transmit all vibration. And also, if the material allows us to slide over the skin without lubrication and not harming the skin, we'll be able to feel more the resistance of the skin, where it slows down or where the friction is higher. We see also an hyperemia specific on the areas where small restriction. All this information we lost it with loop or with a cream. And normally working on the skin without loop with our hands is more complicated. In the Olympic Games of Rio 2016, it was one of the first time that we really experimented the efforts or the effects of the therapy tools. Imagine an Olympic player can't wait 1 week of have results in the recovery of his injury. It has to be something immediately. And the advantage of the therapy tools is really that we have immediately effects on the body and very, very quick. And this is which allows us to be more effective, obviously knowing exactly how to treat in which direction and in which pathway. If we use suction cups, improves also tissue mobility and metabolism. We can elevate the skin, separate it. This allows us to increase the space between the different layers, to increase the growing of fat in this area, which allows better sliding. And the good thing of this tools or cups is that we can use it during the exercise and mobility or mobilization of our patient. So it's like we have more hands on the body, and also the patient can use them at home, which allows to have a mechanical input, which is a continuous stress, which is also very important for connective tissue. The effect is to lift up, but lifting up, because all the connective tissue is interconnected, we are not only stretching the superficial, we are transmitting this tension in the inside. We are creating space inside. This space allows to have a better metabolic effect by increasing space, allowing to remove the metabolic waste, which makes normally inflammation, and inflammation increases the connective tissue, the density, then decrease the mobility, and also the increase of density of the tissue don't allow a good transmission of all the metabolic base and also the nutritional things. So it's a circle which increase the pathology, and removing and creating space in this area, we are able to make this tissue better. The compression of the fascial system allows us also to be very mobile, and the patient also can apply these techniques at home. And we have a lot of shear forces inside the tissue during the exercise. It allows us very, very good things, because under compression we have less pain, under compression we have more force, under compression we have more stability in the joints. Under compression also the joint compression allows a decomptation, or separating the joint a little bit and giving more space for the movement. We can have an input in the proprioception by rubbing in one direction and imagine you are working with an out rotation of your leg, so we can rotate and make the rubbing in the inside rotation, fixing it on the hip. So positioning the leg in the inside rotation, and then allowing the patient to move by himself for a while. And this makes that the brain recognize this new position and integrate it in a movement. We also have a blood flow restriction, which increase normally the growth hormone outshutting, which allows us to get bigger muscles with less weight and with less repetition, which make it more safely. And also the duration of this increase of muscle weight is longer than if we do it without. If we have a muscle injury, if we have blood inside under the compression, we can remove it much quicker, and also to control the inflammation, because we have a blood flow restriction in the area. During the compression, when we remove it, we have a high incoming of new blood, and this will allow us to clean all the metabolic waste in this area and control the inflammation. So you see, compression techniques and mobilization or exercise under compression is also a very, very good tool, but obviously you must know how to apply it, where to apply it, and in which order. The mechanical effect by this compression will also compress all the tissues, will increase the movement in the deep layers and shear forces, which allows to adapt the connective tissue to the necessaries in the area. Connective tissue likes preferably an interaction or be stressed by 5 to 6 minutes, maximum 10 minutes. And in this time, the connective tissue is able to absorb information. All the technique which has more of 10 minutes in one specific area will stress too much and will have a negative effect on the connective tissue. But connective tissue can be activated each 6 hours. This means we can treat it 3 days, 3 times each day. And normally you get treated once by physical therapist if you need it. Normally I only treat it once a week. And then my patients use the compression tools, the decompression tools, exercise to have this mechanical stress on the area to change the connective tissue. And then they do normally exercise about 2 or 3 minutes, 3 times a day, which is very easy for them and which is very effective. Also, if we maintain a gentle tension on the skin with kinesiotape, we can increase the length of the tissue. We can increase the superficial of the skin. So if the skin grows, we reduce the tension, which is very important. We talked also about by the decompression, we create more space between the tissues. We have more fat between the tissues, which allows a better sliding in the area. If we have traction in the area, the fibers of the connective tissue will be aligned in the right direction. But if we only do compression, we have an increase of connective tissue and more density and less mobility. So it's very important that any kind of technique that we do on our body is a relation with stretching. Because if you only make compression like we make in a massage or something like that, we can have immediately effect of a reduce of pain because this has an analgesic effect. It will have also a change of the viscosity of the ground sustain, which allows a better sliding. But at the end, we have an increase of density in the tissue, which is not good. So ever, we need tension in the tissue to allow the collagen fibers to line in a good way. And exercise is very important to be combined with our treatment. The right exercise in the right place, in the right direction to increase the mobility of the tissue or of this quadrant, which are restricted in mobility, and so allow to restore a good proprioception, which allows to take the right decisions to the brain. So, to summarize everything I have told you, we have a body which is very complex in the superficial, formed by quadrants, which allows you to be mobile even that your skin is not elastic. And the skin is not elastic because it has to activate all the nerve receptors in the superficial, which allows the brain to take the right decision. And the transmission of this tension has to be the right one. If there's a reduce of tension in the superficial or an increase of tension in superficial, we have a bad inflammation, which produces a bad mobility and overload in the product. So using the body is mobility to analyze the movements and to know exactly where the increase of tension and which are asymmetry. We know exactly which is disturbing our system, and so we can restore all the proprioception and have a right movement. And then we can take our time to analyze if the pathology is an origin of the asymmetry of tension and the overload, or if the pathology comes from another part, from a metabolic one, from an accident or what else, and was disturbed or increased by the asymmetry of tension in the body. So I hope you liked my presentation. If you want to know more about it, you have my book. This is the Richelli's Facial Pattern System. We have also an English version. We can have it also in digital, very easy. And I'm here open for any questions that you have about my presentation.
A great presentation, sir. Great information. A very wonderful talk, sir. So if any participant want to ask your query, you can unmute yourself and ask the query with our speaker. If you have any question, you can unmute yourself or you can post your question in the chat box. Anyone?
If there's a question in the chat box, I don't can see the chat. So if you see that somebody write, please read
Yes,
me
sir.
his question.
In the chat box, participants are providing the feedback about the session, sir, and the chat in the chat box uh, they are writing that the session is very informative for us like that. But there is no any query from the participant. Shagun sir, are you here?
Yeah, I'm here.
Shagun sir.
Shagun.
Okay. Okay. So I think there is no query, sir. Yes. So, sir, kindly accept a digital memento uh, on the behalf of Golgotha University for this virtual session. We have created a virtual e-memento for you. Okay. Yes, sir.
Thank you so much.
Thank you. Thank you so much, sir.
And well, if no is no question, maybe tomorrow or what else there on my presentation, you have my email, you have my WhatsApp number, so you can write me the question that you maybe have in the next days.
Thank you once again, sir.
No, I mean that maybe the people right now don't have questions because there's a lot of information and new stuff, but maybe in the next day they have any questions. And on my presentation on the last slides, there's my email. They can write me and ask me anything that they want about my presentation.
Okay, sure, sir. Sure, sir. Thank you. Thank you so much, sir.
Sorry?
Yeah, thank you. Thank you so much, sir.
Thank you. Thank you so much.
Thank you, sir.
Okay, you need anything else?
Yes, sir. We are still waiting for the participant. If any participant have the query, they will unmute themselves to ask.
Okay. Nobody wants to ask me nothing?
Yes, sir. It seemed to. So, thank you once again, sir, for joining us and accepting our invitation.
You're welcome.
So, dear participant, we are waiting for our next speaker.
Thank you, Stephen. Thank you for valuable time. You have given your knowledge about the fascia and all. Okay. And we would like if we physio would be using your tools and all. Am I audible, Dr.
Yes,
Stephen?
sir. Actually, sir, Stephen, sir, now left the meeting.
Okay.
Yes, sir.
Sorry, I would call him back. And our next speaker, he is in the hospital. He is joining within the 10 minutes. Okay. Within the
Okay, sir.
10 minutes, he is joining us. Yeah.
Yes.
Hello, good evening, everyone. Hi, this is Dr.
Good
Sumant.
evening, Sumant. Good evening. Dr. Gaurav, Dr. Sumant is there.
Can you hear me?
Yes, sir. Yes, sir. Yes, yes. Give me 1 second, sir.
Hello.
Yes,
Good
sir.
evening,
Yes, sir.
everyone.
Good evening, sir.
Hi, good evening, Dr. Gaurav. Can you hear me?
Yes, sir. Yes, sir.
Yeah, you're a little bit less audible to me. Okay,
Okay.
am I audible?
Yes, sir. You are perfectly audible.
Okay, okay, great. So, so we can start. In the meantime, I will just start off with my laptop also.
Yes, sir. You can share, sir. Let me introduce first, sir. So, dear participant, sorry for the delay in the second session, and it is with our great honor and privilege that I am introducing our distinguished speaker, Dr. Sumanta Ghosh, sir. He brings over 14 years of extensive experience in the healthcare industry, marked by diverse skill set encompassing the teaching, product management, clinical expertise, sales management, and customer relationship management. With a proven track record, Dr. Ghosh has excelled in various roles, demonstrating exceptional abilities in project implementation, team leadership, and goal achievement. Currently serving as an associate professor at ITS College of Physiotherapy in Ghaziabad, Dr. Ghosh is also an approved faculty member of the Gujarat State Council for Physiotherapy in Gujarat. Alongside his academic commitment, and he is the co-founder of Health Specific India based in the Noida, reflecting his entrepreneurial spirit and commitment to advancing the healthcare solution. Sir has advanced career journey that include the notable positions such as marketing manager at Zimmer India Private Limited, deputy manager at Philips Home Care Service India Private Limited, and the role of significant responsibility as in charge of respiratory therapy and respiratory care unit coordinator at Max Hospital in Delhi. He holds a Master of Cardiorespiratory Physiotherapy from Jamia Hamdard University, BPT from ITS Medical College, and his academic achievement coupled with the practical experience across various sectors of the healthcare industry underscore his dedication to in enhancing the patient care, customer satisfaction, and quality standard. He has also a winner of several awards, so namely finalist of WHO call for the abstract for the emergency, Zimmer India Impact Award, Young Achiever Award, Global Outreach Healthcare Award for the excellence in respiratory physiotherapy, Spotlight Awards, significant contribution to physiotherapy award, CEO award, S7 World Cup winner award, and Physio Entrepreneur Award, Hall of Fame, North and HO Business Impact Award, and many more. So we are highly privileged and fortunate to introduce sir, and we are inviting you. We are feeling honored to inviting you, sir, for the keynote talk. Over to you, sir.
And namaskar everyone. So I am Dr. Sumanta Ghosh and I am very very thankful to Galgotia University, and my special thanks to one of my teachers and seniors, the Dean of the Allied Health Sciences of Galgotia University, Dr. Shagun, for giving me this opportunity and inviting me for this talk. And I have been fortunate that I am amongst all of the esteemed faculty of Galgotia University as well as of other colleges and esteemed institutions. So I would like to introduce myself. I think very thankful to Dr. Gaurav for introducing me and giving a elaborate basically introduction. But for speaking about myself, so I am a person who has been a clinician and also in the basically medtech space. So I have been very very fortunate to have worked with very very great physicians, very great clinicians, all also the leaders in the health tech university, which is very very important in terms if we see the whole healthcare industry of India. And if you look at the healthcare industry, especially in India, which is about going to reach around $40 billion, the market very very soon, and going at a CAGR of more than 21%, which is basically more than many of the other industries. So we have to be basically very much aligned with our objectives of reaching the maximums of society. And I think as faculty members of various institutions and also academicians, clinicians also, we will be playing a great role in reaching out to the maximum public. So my topic for today is basically the role of respiratory care and pulmonary rehabilitation in decreasing the chronic respiratory burden in India. So as the topic suggests that today's topic we will be talking about your how respiratory physiotherapy, which is respiratory care, pulmonary rehabilitation, would help us in join basically decreasing the burden by offloading the patients from the hospitals, maybe treating them on OPD basis, maybe reducing the burden in terms of the number of years that lost because of the chronic diseases. And India is somehow or the other becoming the capital of chronic diseases in India. We are already the diabetic capital. If you look at the chronic respiratory disease number also, so just trying to open my PPT in the meantime, but if you look at basically the chronic respiratory diseases, so we are like around basically the third largest killer of India is the chronic respiratory diseases as of today. So just give me a second, I'll try to open my PPT. Dr. Gaurav, I'm just trying to open the Teams app is somehow taking a little bit time in the laptop. Just give me a second. So in the meantime, to keep it interactive, so if I could get an idea, more I think physiotherapy faculty are already here, which I do know, and the Department of Biomedical Engineering is also there. Dr. Gaurav, I think you're mute.
Yes, sir.
Okay, and any other departments also?
Yes, sir. Basic and applied science is there. Pharmacy faculty is there. Some management faculty is also there. The computer science faculty is also there. So the faculty from the different background who are interested in the biomedical science and engineering research domain, they have joined, sir.
So I think they've been privileged to have all of the esteemed faculties here today.
So we have received, sir, more than 700 registration from 26 states, but I think approximately
Oh, wow.
um, 18 states faculty member have joined this FDP.
Oh, great. I think this has been one of the most successful FDPs that I have been a part of. Just give
Thank
me
you
a
so
second.
much.
I'm so sorry, everyone. This Teams is.
Sir, if you are
Dr. Gaurav,
facing
can you
the
see me
difficult,
with the other login? Uh,
sir, you can share the PPT to Shagun, sir. I think he will send me, or uh, sir,
I have,
in between the mic and leave button, there will be a share button. So just
Sumant,
click on the share
you
button.
can share me on WhatsApp if you want. You can
okay,
share
so
me on
just,
WhatsApp. I will share to Gaurav sir.
Yes, just click
okay,
on the
okay.
share button, sir, and choose the screen. Select the screen, and you can share the whole screen. Uh,
Just give me a
After that,
second, sir.
the PPT will be visible.
Just a second, sir. Hi, Dr. Gaurav.
Yes, sir.
Yeah, I think hopefully you can. Yeah, so I need to share the screen. It will be on the side of the mic, right?
Yes, sir. Yes, sir.
Only meeting organizers and presenters can share. So if you
Uh,
can, Dr.
okay.
Sumanta PC, if you can make the
Okay.
presenter.
Okay. PC. Okay. Uh, Now, sir, you can present.
Okay, thank you. Yeah, hopefully the screen is visible now.
Noted, sir.
Says no, I think it
Yes,
is
sir. Yes,
visible
sir. Yes,
now.
sir. Yes, sir. Yes, sir. Yes, sir.
Thank
The
you.
screen, whole screen has been shared, so you can
Yeah,
open the PPT.
yeah.
Yes, sir.
Just give me a second. So sorry, everyone. Just give me a second.
Yes, sir.
Yeah, just give me a second. Actually, there is some issue with the laptop. It's hanging. Just give me a second. So sorry. If this is not there, this. Yeah. Actually, just give me a second. Just taking it from online. Just give me a second. Just give me 1 second. I think I having some issue with the PPT, but we will continue. So, in the meantime, I'm trying to open up the PPT. So I'm so sorry, everyone. So what actually the main problem? What is chronic respiratory diseases? So I think we have variety of faculties here, and I think most of us know what are chronic respiratory diseases. But to basically begin with, what are chronic respiratory diseases? Chronic respiratory diseases are a set of diseases which are affecting our respiratory system. As the name suggests, they are chronic in nature. So there are basically mainly two types of chronic respiratory diseases that involves us, and that can be categorized as obstructive. So obstructive diseases are any diseases which are causing an obstruction in your airway. So if you look, so what happens is, if you look at the anatomy of our respiratory system, it starts from the upper respiratory tract and the lower respiratory tract. So if you look particularly at the lower respiratory tract, so what starts from basically the bronchus, which divides into two principal main bronchuses, which goes further divides and basically goes up to the alveoli. So this has basically, if you look at, some are the only the conducting systems, wherein the main role is to conduct the air up to the alveolus, and some are respiratory, basically the part of the respiratory system. So in the respiratory part, the actual gaseous exchange takes place, wherein the body takes in the oxygen and gives out the carbon dioxide. So this is mainly the obstructive and the restrictive diseases, right? So when you look at basically the obstructive diseases, so what you have is most commonly the highest number of patients are there of COPD, which is chronic obstructive pulmonary disease. What is chronic respiratory pulmonary disease? If you look, chronic obstructive pulmonary disease is a disease which involves the airways, wherein the airways are becoming smaller and smaller because of the age and the disease progression. So what are the predisposing factors? The most important predisposing factors for COPD is your smoking. So if you are a primary smoker or you are a second-hand smoker, and also the pollution involved. So what happens is the airways get affected, and if they are this much, so they become smaller and smaller. So there is another basically type of obstructive disease, which is called bronchial asthma, wherein the airways are becoming small, but that is not permanent. So there is a reversibility. So when to diagnose this obstructive diseases, the gold standard for them is basically to do is a spirometry. So what we do is we do a PFT, so pulmonary function test, wherein the patient comes and blows into a turbine, which is a mechanical or an ultrasonic turbine, and that records that how much is the volume that has been expired in the first second and also in around 6 seconds. So which gives us two very important values, that is the FEV1 and the FVC ratio and the FEV1 values. So according to that, we look into the disease and we categorize into a obstructive or restrictive. Now, if the patient is an obstructive patient, so if a drug is given, such as a bronchodilator drug, so which can be a short-acting beta-2 agonist, and the test is reconducted around 15 minutes later, and if the values of the FEV1 by FVC ratio, if it is improves by around 12%, it is called as basically bronchial asthma. Otherwise, it is called as a COPD. So these are mainly the obstructive diseases. Apart from this, one of the most common obstructive diseases now that is involving our society is the obstructive sleep apnea. So you must have seen many patients or individuals nearby you also, which have a habit of snoring, right? So what they do is, while sleeping, they will do this sound. But why it is happening? Because while sleeping, because of the size of your neck and because of the fat accumulation in the neck, and because of the progressing age, what is happening is your airways are becoming narrower and narrower day by day. So what happens is, because the airways become narrow while you sleep, so when you're awake, there the muscle tone is there. So all of you know that when we are awake, there is a muscle tone in every muscle group. So is the basically muscle tone available in the glenohyoid muscles, etc. in the neck, right? But what happens is when we sleep, all the muscles go into relaxation. So does the upper airway muscles. So mind you that there is no absolute bone in the upper airway, right? So to protect it from collapsing. So what happens is if the muscle collapse, the airways also collapse. So when the airway is collapsing, what is happening is if it is going collapsing, so if it is more than 50% closed, it is called as a hypoapnea. Whereas when it is basically fully closed, it is called as an apnea. So what will happen is patient will do this into hypoapnea. And then what will happen is after some time, he will go into apnea. So and and you will get wait. So what is this? Is basically patient is going into hypoapnea and apneas. So now when the patient is going into this hypoapneas and apneas, suppose the AHI, the apnea hypoapnea index is basically maybe 20 or even higher. We have patients who have apnea hypoapnea indexes around now 50 also. That means in 1 minute the patient is waking up 50 times. So is not sleeping at all. So what is the major problem with this? If the patient is not sleeping only, so patient will have daytime sleepiness, he will have headaches, he will have lack of concentration, but more importantly, it will also start affecting his endocrine system. His hormones will go haywire. He may basically have hormonal disbalances or can have basically increased blood sugar levels, increased thyroid levels, and also there are chances that the patient's cardiac system will also get involved, and then the patient has a risk of basically your heart attacks, your heart failures. So there is a huge chance that the patient will go into a cardiac failure. The patient can also go into a ischemic stroke because of this. So all of this together, it makes it a very dangerous condition. So apart from this, there are other basically conditions, respiratory conditions, which will hamper the patient. So the other respiratory conditions like the restrictive conditions. So restrictive conditions, there are a lot of restrictive conditions. But if I tell you briefly, the restrictive conditions can be with the restriction of the gaseous flow, what is called as the interstitial lung disease, wherein the interstitial of the lung tissue is become so thick that the gaseous exchange is not happening. These are mostly called as IPF or ILD, interstitial lung disease. And what happens is because of this fibrosis or interstitial thickening, the gaseous exchange is not happening and the patient's oxygen levels are going down. And this are also a basically life-limiting disease, and the mortality is also there in this kind of disease. So the other kind of restrictive diseases that the chronic respiratory diseases have is also your diseases of the neuromuscular origin. So neuromuscular origin, it can be the basically any disease which is involving your respiratory centers like hemorrhagic stroke or ischemic stroke, or it can be your spinal cord injury, higher spinal cord injury, where the connection, the blood supply to the diaphragm, which is the primary muscle of breathing, has been hampered. So that can also be there, right? So primary muscle of breathing, the diaphragm, is situated somewhere between the thorax and the abdomen. When the diaphragm goes down, it creates a negative pressure. Air comes into the lungs. Very simple physics, right? So what happens is if the connection to the diaphragm is cut, if because of a spinal cord injury, so diaphragm is not working at all. So what is happening is because of this, the patient is not able to breathe in, one of the restrictive conditions. Other restrictive conditions being progressive neuromuscular diseases like a Duchenne muscular dystrophy, Baker's dystrophy, etc. Okay? So what is happening is the muscles are going into degeneration. The child has this disease around 6 to 7 years of age, and while he progresses to the age of 14 to 16, he almost has the mortality because every muscle is involved, and slowly the respiratory muscles are also getting involved, right? So other kind of restrictive diseases is also your basically the muscular origin neuromuscular diseases like myasthenia gravis. I think myasthenia gravis most of us know because some of the celebrities are also having this, and this also causes progressive muscle weakness, including the muscles of breathing, and that's why it is also basically taken as a chronic respiratory disease. So this is about the respiratory diseases. So any questions, any comments from any of the esteemed faculty? Hopefully you are now able to see my screen also regarding chronic respiratory diseases. Any one of you, many of you must have treated them. Many of you have must seen patients with them or also done some research or work on the same. So any one of you regarding the chronic respiratory diseases, any comments, any basically anything you want to share? Because hopefully we have lost some time, but we'd like to definitely make this session very, very interactive. Any esteemed faculty? No one? Dr. Gaurav, am I audible to everyone?
Yes,
Dr.
sir. Yes, sir.
Gaurav?
You are audible. Yes, sir. Yes, sir. You are audible.
Okay. Great. So now coming into the chronic respiratory disease impact in India. So what if you look into the chronic respiratory diseases? So if you look what is the prevalence in India, and this is the India data till 2019 and or 2020. So it does have the data after the COVID, but we know that till that time also there are around 65 million people who are suffering from this respiratory diseases, and it is the third largest causes of death in India with over 1.1 million deaths. But more importantly, if you look at the dailies, what are dailies is disability adjusted life years. That means how many years average basically is lost by people with fighting with this chronic respiratory disease. 29 million years altogether lost because of the disability related years. So every patient nearly losing around basically 1.5 to 2 years of his life because of this disease. And this causes the disease, as we progress, we will see if this progress disease not only causes the problem to the patient, but causes also a huge economic burden. So now, if you look into the economic burden, so if you look, so this is research articles published in the European Respiratory Journal. So this is published in 2022, and it says that if the patient is, if you're looking in India, and if the patient is basically spending quite an amount of money. If you look at the average money spent, it somewhere becomes around 18,000 to 22,000 rupees per month that the patient spends on basically hospitalization, on the medications, on the different therapies that is going on there, like pulmonary rehabilitation, etc. So overall, there is a huge basically the economic impact. And if you look at on the left hand side, so if you look at the burden increases as the severity of the disease increase. So more, and it is basically the severe disease patients are the most affected economically because very severe, there is also mortality in this stage. So how do you basically decide what stage of COPD? So just to give a gist, so what we do is when we're doing this PFT and we're looking at the lung function, the FEV1 by FVC ratio. So if it is less than basically 70%, it is mild. Then if 70 to 50%, it is moderate. Basically 50 to 30%, it is severe, and less than 30% of the lung function, it is very severe disease, right? So when it is a very severe disease, it is the economically the most affected people are on the severe COPD group. So any questions up to this? Any one of you? Any questions? Any comments? Most welcome.
Yes. If dear participant, if you have any query, you can unmute yourself and ask the question.
Yeah, please kindly unmute and we can have a good discussion. No one. So now, if you look at the state-wise basically division, so if you look at basically per 1 lakh patients, the prevalence. So if you look at the most basically reddish states, where it includes our own Delhi, it includes parts of Uttaranchal, it includes Uttar Pradesh, Haryana, etc., which is most affected, and more than 4,750 people among 1 lakh people having chronic respiratory disease, right? So, if you look into the whole of India, it is not like that only the northern region, where is the most polluted region of India, is most affected. It is definitely most affected. But the other states, as far as basically, if you look into states which are nearly basically greener states compared to other parts. If you look into my home state, Assam also. So there is also a huge prevalence there also. This relates not only to the environmental pollution, this is only also because of the smoking prevalence in our country, so which is causing a problem. And in earlier times, so it was also the use of fossil fuels to cook food was also a major contributor to this. If you look at the season-wise distribution here in this the down, so what you can look is that these diseases. So if you have experience of any chronic respiratory disease patient, suppose a COPD patient, this COPD patient have basically seasonal variation. So what happens is, as the winter starts, their acute exacerbation or basically acute infections or acute flare up of the disease occurs, and the patients are admitted to the hospital or starts. So I start around the time of Diwali here in northern India, and it goes slowly up, and it is there till March end. Right, so the disease burden is most during that time for the chronic respiratory disease patients, and they are very susceptible to basically mortality as well as morbidity during this time. So if you look at the particularly a division of the pulmonology patients or the respiratory medicine patients. So if you look, COPD is 55% of the chunk. So 65% of the patient that comes to in OPD of a respiratory physician is COPD. 45% are non-COPD, and in the non-COPD group, if you look into the non-COPD group, 29% around is the asthma ILD that I have discussed. Then there is acute infections of around 21%. So this is a further division of the 44% non-COPD that I am talking about. The pneumonia patients around 21%, right? Tuberculosis is a huge 17%. The neurological cases that I have discussed in detail is around 28%. And then post-trauma, post-surgery patients are also there around 5%. So if you look at the COPD distribution, so how much percentage does normal OPD sees for the type stages of COPD? So you can see the stage 3 is the highest, at around 40%. Stage 2 is the second highest, right? So now, what are the patient burden and the pain points for this? So if you look at the major patient pain points, so what is happening is that the treatment, despite treatment, there are treatment failures and the patient is going into multiple hospital admission. In India, so there is always some delay in making a decision to shift to hospital or not, and that increases the disease. And then when he is basically admitted to the hospital, most of them are out of pocket payment. So insurance cover is not there because these are mostly senior citizens or patients who are above 45 years of age. Well, some people doesn't have the insurance, and then there's a direct impact on the patient's pocket there, and the patient is usually affected, right? So there's also burden on the family that is coming on because of the economic burden, also the emotional burden, and also if you look into the cost here, so hopefully the slides are visible to everyone. So the average length of ICU stay is around 4 to 6 days for this kind of patients. And then what happens is, if you look into the average expenditure that in each hospitalization has, is somewhere around, basically, if you're looking at tier 1, tier 2 city also, the metro will be even more. So the patient spends around 3.5 lakh rupees, which is huge economic burden to the patient and the patient's family, apart from the psychological aspect. So now, how can we prevent this? So prevention of any disease basically starts at your individual level. So if before going into the community, we should be doing it for individually also. So if you look into it, so first thing is basically stopping the smoking. So going into basically smoking cessation program helps a lot. So there are good smoking cessation basically people who practice dedicatedly cigarette smoking. So that can be tried. Also, pharmacological therapies in the smoking cessations are working a lot. But along with this, non-pharmacological therapies also play a very key important role, like cognitive behavioral therapy, etc. So now also. If you look into basically, I always say there are four pillars of health that we should always work upon. The first thing is the good sleep. So if you do not have a good sleep, you will not be active, you will not be able to do anything. Good amount of sleep is very necessary. Next important thing is the exercises. If you do not exercise, there is lot here that you're missing out, and the body will not be able to cope up. Then the third thing is good food or good nutrition, which is very important. Natural supplementations, and we have been a traditionally society which if you look into our traditional recipes, or if you look into the home remedies that have been prevalent and that have been passed on from generation to generation in here India. We are very rich in medical herbs. We are very rich in basically using of natural elements like water, heat, also using your naturally available food supplements like turmeric, ginger, etc. to great extent, right? So this helps a lot. Then also preventing in terms of this patients required, the chronic respiratory disease patients, the vaccinations of the patient, a flu vaccine, right, helps a lot of preventing the diseases. And then also preventing from the external things like prevention from pollution is very important. Prevention from also, if you can see why have I put a pigeon there, because one of the main causes of interstitial fibrosis here that we have been seeing recently, and there's a lot of flare up, is the pigeon pandemic. What is happening is because of the pigeon droppings, pigeon feather, etc., and some patients have sensitive to that, and because of this, the autoimmune IgG bodies form of body. This basically pigeon droppings and for the pigeon feathers, and the patient develop interstitial lung disease. So prevention from direct exposure to the pigeon droppings as well as pigeon feather also plays a very good role at individual level. So now at community level, I think this the 65 million people that we see are having chronic respiratory disease. They are coming to the OPDs at around the third stage or at the end fourth stage. So if we do regular medical camps, maybe we'll be able to dedicatedly find out patients who are in the stage one also. And now we hardly see patients at stage one because the patient is young, is less affected. But yes, the disease will increase. So if we catch it early, we can give the preventive strategies, the pulmonary rehabilitation, the medications at the right time, and this will help in the patient not increasing the disease level or not progressing out in the disease, right? So this, if you look into this, here, if you can look here, so this is the government guidelines. So basically for the diagnostic criteria, investigation, and referral criteria. So it says that if you are basically looking into a patient and if you think there's a clinical history of chronic cough, exacerbation in the winters, is a smoker, right? Or has occupational exposure to any kind of smoke or any kind of pollutant, then with examination of bilateral, basically you look at into bilateral chest, there is the barrel chest deformity. If the patient is doing pathological partially breathing like this, right? So if you know that on percussion there is hyperinflation, by doing diagnostic percussions, you can see if there is any dynamic hyperinflation patient, indirectly, if you see a bulle, that means there is maybe a chronic respiratory diseases, right? So if the hemogram is showing polycythemia, X-ray showing hyperinflation, then definitely you should look into as a chronic respiratory disease and start treating at the primary level also. Physiotherapy being our primary healthcare professionals with the new NCAP Act being passed on. So physiotherapists have also great responsibility on doing it at the primary level as a primary healthcare practitioner to find out the chronic respiratory disease. And this can be done with patient awareness activities, patient camps, right? And then also there are a lot of awareness that can be done on online Instagram stories. Basically, your Facebook campaigns would help a lot in increasing the awareness, right? So then also at community level, we are as a society or as a country, we are moving towards slowly, very slowly moving towards greener energies, hydrogen being one, the basically electrical cars, etc. being one. Solar energy has been given a lot of focus now, and I think with the new rooftop solar scheme, I think more people will adapt to greener energies, and there will be less pollutants, right? Which will help in further decreasing the pollution levels and stopping this chronic respiratory diseases. So these are the preventive strategies. Any questions and comments up to this? Any one of you? So faculties, I'll request you to keep on adding your points because otherwise other people will miss out with your extreme knowledge. So any comments? No comments? Okay, let's carry on. So now if you look into a patient of chronic respiratory disease, what is happening to this patient is, if you look into particularly what is happening to this patient. So now the patient is having, because suppose I'm taking the example of a chronic obstructive disease patient here. Suppose the airways have become small, right? The airways are small now, the air is having difficulty in entering. So what is happening is patient is having mild symptoms of breathlessness. So he's doing mild basically use of the accessory muscles because the primary muscles is not able to put in the effort that it should have, because what is happening is because it is continuously working against a obstruction. Slowly, diaphragm, which is a dome-shaped structure, slowly becomes so weak because it is tired. So it is just like if you give your students 50 pages to read, it is okay. But if you give 200 pages to read in one day, it will be too much, and the student becomes basically fatigued. So what happens is here our diaphragm is also getting fatigued because there is obstruction here, is continuously working against this obstruction, and this diaphragm is getting flattened out. So now when this diaphragm is getting flattened, so the diaphragm is not able to pull in the air that it should have. So generally what we say is that the normal individuals, we should be able to pull in at least 8 ml per kilo ideal body weight. So if I am 170 centimeters, 70 kilo is my minus 100, is 70 kilo is my ideal body weight. That means 70 into 8, 560, I should be 560 ml of air, I should be able to breathe in every breath. But my diaphragm, instead of producing full 100 centimeters negative pressure, supposedly when it came down, it produces minus 100 centimeter of basically pressure. But now, because the diaphragm is not dome, it is flattened, it is weak now. And because of this, what is happening is it is producing less negative pressure, less air is coming inside. So more use of accessory muscles, more breathlessness is happening to this patient. Now, another problem is because the diaphragm is not going back to its original position, it is not able to expel out the air also. So there is carbon dioxide accumulation, but the major problem is that there is a production of intrinsic peak or auto peak inside the lung, which is continuously trapping some air. And because of this, the lung sizes become very big in COPD patient, which is called as a emphysematous lung, right? So now there is respiratory muscle weakness, as we can understand, because of dynamic hyperinflation and because of working against the chronic obstruction of the body, of the lungs, and because of this, the patient symptoms is increasing. Because of this, now patient is doing less of an activity, patient is walking less, and because of this, his functional capacity is going down. His basically peripheral muscles, the leg muscles, the thigh muscles, etc., are becoming very, very weak. And because of this, if it is getting very, very weak, the patient is walking less, his 6-minute walk distance is decreasing. Ultimately, the patient becomes psychologically affected. Even if he's given the best of pharmacological therapy in terms of the short-acting beta-2 agonist, long-acting beta-2 agonist, inhaled corticosteroids, but still the patient is not able to recover fully. Right? If his quality of life is happening, there's definitely nutritional deficiency comes in, and this progresses the disease even faster. So what can we offer? So what we can offer is something that is called as pulmonary rehabilitation. So what is pulmonary rehabilitation? Pulmonary rehabilitation basically is your rehabilitation of the lungs. So it is a structured program. It is not limited only to your this thing, only the exercise component. It is also includes thorough patient assessment, right, which includes assessment of your respiratory muscle strength, which can be done by a simple manometer, which can measure plus minus 200 centimeters of water. So if we take an inspiration and it is measuring the negative pressure with the respiratory muscle strength, right? So you can use simple equipments like that. So we can also use your equipments like your this thing to assess the 6 minute, which doesn't need any equipment. It requires just a walking of 6 minutes in a plain surface in an indoor area. We can measure the strength of the peripheral muscles. So we assess the health related quality of the life, nutritional status with a basic electrical impulse analysis. What happens if the patient stands in a BIF device which sends an electric impulse which goes throughout the patient's body, and the machine receives it back, and it gives around 7 to 10 key contents, including the body fat content, with body water content, body protein content, which helps the dietitian or the nutritionist to further plan a very good diet plan for this patient. So it is complete teamwork here. The patient, if he is hospital anxiety and depression score, or if it is involved more basically it is anxiety and depression, and the scores are above 11 on the HAD score. So we involve definitely a psychologist or a psychotherapist for further better management, and also the good treatment, good medical treatment is to be given by the pulmonologist. So now, as you can see, pulmonary rehabilitation, the main aim of pulmonary rehabilitation is to now decrease hospitalization. So, if you are doing good pulmonary rehabilitation, what you should be able to do is you should be able to reduce the number of hospitalization of this patient. So, you should be able to reduce the emergency visits. So, we should be able to reduce the shortness of breath, leg discomfort. But you should be able to increase the exercise capacity of this patient, which is very important, right? So also we should be able to improve the emotional status and the health related quality of this patient, right? So these are the major aims of pulmonary rehabilitation. So what we do in pulmonary rehabilitation? In pulmonary rehabilitation, if we specifically speak of the exercise therapy part, what we do is aerobic training, which is working against a specific aerobic load, which can be targeted by a heart rate, right? So you walk in such a way, or you do the cycling in such a way that you reach till a certain heart rate. Suppose my resting heart rate is around 80, but when I do the cycling, I should be able to reach around 110, which is basically my target for basically doing the exercise for today, because we do around 50 to 70% of the aerobic capacity, right? Then we do the strength training for the upper lower limb muscles, because there is something also called as metabaroreflex. That means when we do activity, the muscle which is most involved, the instead of that muscle, the basically oxygen is diverted toward the diaphragm, so that the diaphragm can keep on walking. So this upper extremity, lower extremity training is very important. One of the very important training is the respiratory muscle training. So in respiratory muscle training, we tell the patient to breathe against a resistance, which helps in the patient, basically developing more of the respiratory muscle power, improving the diaphragm strength, the diaphragm goes back to its original position so that there is less of symptoms and less of breathlessness. Then we also do balance training. Patient education is very, very key important role in chronic respiratory disease patients. Oxygen supplementation, non-invasive ventilation plays a very, very critical, basically, therapy which is required, and then nutritional supplementation is required. So any questions on this? The pulmonary rehabilitation, why it is required, and any one of you think that it is important? No one? Okay.
So dear participant, please be interactive and you can unmute yourself also to ask your query.
It is not about asking questions actually. So it is just sharing the knowledge. I think everyone is a faculty member here. So I think
Yes,
it
sir.
is
Yes, sir.
just basically, so this discussions make us better accommodations that I feel, and I think that could definitely help.
Sure, sir. Sure, sir.
Right. So now, pulmonary rehabilitation, what are the main recommendations from the basically bodies like the American Thoracic Society or the European Respiratory Society is that stable patients should be enrolled, patients in the hospital also should be enrolled, and this should basically involve the patient wherein there is also, yeah, any questions? Dr. Prem?
Okay. I think that is technical thing, sir. You can continue, sir.
Yeah, no problem. So barriers to pulmonary rehabilitation in India now. What happens? What is happening is there are several barriers to pulmonary rehabilitation, wherein we are here to discuss how we can break the barriers of pulmonary rehabilitation and providing respiratory care to the patient. So one is the physician related because the patients mainly go to the physicians when they are having this problem, and physicians do they have some knowledge about pulmonary rehabilitation, but what happens is because they are not been involved in the pulmonary rehabilitation uh, during their training or during their MD and DM courses, so they have inadequate knowledge of how a structured pulmonary rehabilitation program looks, and they try to decrease the cost and the time of the patient. They try to teach some home exercises, which is not very very adequate enough because it needs a structured training of at least 6 weeks, at least twice a week for 6 weeks. That is the minimum required for a good pulmonary rehabilitation program. It can more, it could more merrier, but it should be minimum 6 weeks and two sessions per week, right? So 12 sessions in all should be there, right? So now this is the limitation to the physicians, which can be basically done by involving more crosstalk, more interdisciplinary workshops, conferences, etc., which will help further. Right. Then for rehab professionals, so there are very very less rehab professionals also which specializes in pulmonary rehabilitation. So more people. So we have been trying to. This is we've been involved with the WHA training also. So we have been training around last year. We trained around 1,800 physiotherapists in pulmonary rehabilitation and respiratory care services, so that they can be more involved in their respiratory care of the patients. So that is also basically lack of dedicated respiratory physiotherapists. So masters of cardiorespiratory physiotherapy, at least with some additional training in pulmonary rehabilitation or respiratory care helps, right? Then involvement of other professionals are very, very important, like dietitians, psychologists, like, and then also incorporation of digital systems, which is a key role. And I think the future will be AI guided telepulmonary rehabilitation. So because to reach the mass number of people in India, so we have to involve technology, and technology should be not a barrier, and it should be a barrier breaker. So more we use technology in a positive way, more people will to use. And I think next big thing in the space of respiratory care and pulmonary rehabilitation will be the involvement of basically the AI networks, the large language networks that are coming in, and which will help in further assisting the rehabilitation professionals in doing the rehabilitation. Right. So, other the patient-related barriers, all of you know, there is the economic barrier. You need to understand that if you are paying for a respiratory package or a pulmonary rehabilitation package for maybe 15-20,000 rupees, but if you're even getting one hospital admission free for in 1 year, so if they are not getting admitted even for one time, so they are saving at least 4.5 lakh to 5 lakh rupees. So that is one thing. The other thing is there should be more knowledge of pulmonary rehabilitation among the patients. That should come from more into mass media, social media, etc. And then also insurance coverage. I think insurance has started covering post hospitalization expenses now. And I think that it is a good time to enroll the patients, but OPD based enrollment should also happen so that the patient can get enrolled and can have the benefits of the respiratory care. So if you look at the pulmonary rehabilitation patient journey, what happens is generally patient contacts the physician or the pulmonologist, respiratory physician also, and they are basically encouraged to enroll for a pulmonary rehabilitation program wherein goes to a PR center like ours. It is counseled by the basically counselor, and then uh, the patient is made to choose from OPD-based pulmonary rehabilitation or a home-based pulmonary rehabilitation or a basically your tele-rehabilitation. And what we believe or found out is that if the patient cannot come to OPD-based pulmonary rehabilitation center for any of the things like distance, etc., or the lack of people in the patient's home, so a mixture of home plus tele-rehabilitation works very good. But for assessment and for the initial 1:1 contact, the patient and the therapist interaction remains a very, very critical part. So, and then the patient enrolls for a 6 minute, 6 week pulmonary rehabilitation program. It can be either of center based, home based, or tele-rehabilitation or a hybrid mode that I have discussed. Then the assessment of the patient is done and the patient is enrolled into the program, and the exercises, nutritional supplementation, and the psychological therapies of the patient starts, right? So this is how the patient journey happens. So now, if we look into the other aspects of the technology that has been playing around this is the non-invasive ventilation and the sleep therapy or the sleep diagnostic and sleep therapy. So before coming to that, I would like to basically again request any of the faculty members if they want to be interactive or want to add anything. So it is just for basically the sake of everyone that will benefit. So any comments,
Yes,
any
sir.
question, anyone?
Sir,
So
someone
that
has
we can move
Muhammad
part.
Ansari has right. The
Yeah.
PR related to cardiac arrest.
So pulmonary rehabilitation is not related to cardiac arrest, but the respiratory failures. So, we have two types of respiratory failures, as all of us know. So the type one respiratory failure, wherein the oxygen is going down, and because the oxygen is not passed into the body, where it is a pneumonia, like there was in the COVID, right? And then there is a type 2 respiratory failure, where the carbon dioxide of the body is basically increasing because it is not able to come out, as I told you, in the COPD, right? So pulmonary rehabilitation helps in your COPD patients and also your ILD patients or the pneumonia, post-pneumonia fibrosis patients. So yes, pulmonary rehabilitation is more for the your pulmonary patients, and cardiac rehab is for the uh, basically cardiac rehab and pulmonary rehabilitation. In some things are similar. The components of both are similar. Only in cardiac, after the cardiac arrest, there are certain more precautions, and the basically duration of the program, the intensity is slightly vary. So hopefully this you got your answer, Dr. Ansari. right?
Sir, there is another question from
Yeah.
Dr. Sanjay Kumar Mishra. What are
Yeah.
the sign and symptom of COPD?
So what are the sign of symptom of
Symptom,
COPD
yes.
is basically the first the symptom of COPD is your breathlessness. The patient will have some breathlessness. There can be cough, chronic cough involved, which is not because of any kind of infection. There can be sputum production. There is another disease called bronchiectasis, where there is more increased sputum production. But in COPD also there can be increased sputum production, and this disease are characterized by acute exacerbation. That means the patient will get sick when the seasonal, basically the cold season starts or something, will get a pneumonia, get admitted to the hospital, right? So these are the main signs of COPD. So the first thing is your breathlessness will be the first symptom that the patient will have, along with accessory muscle weaves or increased work of breathing, and the PFT will show his obstruction in the PFT. So I think this will give the answer to your question. So I think another question is there. What are the risks of pulmonary rehabilitation? So per se, there is no risk of pulmonary rehabilitation if the correct patient is selected. So patients who have undergone recent myocardial infarction, the patients who have unstable coronary artery disease are not suitable patients for pulmonary rehabilitation because this needs some kind of stress. But otherwise, in pulmonary patients, even earlier we were not doing pulmonary artery hypertension patients, but now we are also doing the pulmonary artery hypertension patients also. So yes, it has very less amount of risk as such. Dr. S, I think hopefully I am able to answer. So
Yes, sir.
we will
He has
continue
also
with the.
provided the feedback. Nice presentation by you.
Okay, so much. Thank you so much. And
Yes.
I am extremely sorry for the delay that happened in the beginning because there was some mistake problem
Yes.
with the laptop. So now coming into the second part of our this thing, hopefully, Dr. Gaurav, we have the time to carry on with the second part of the presentation.
Sir, next speaker has joined with us. So
Okay. So I'll just basically quickly run off with a few slides. So
yes, sir,
the
you
other
can
thing is
conclude
basically,
in
as I
5 minutes,
as
sir.
I
Yes,
told
sir.
you that these patients are getting admitted to the hospital frequently and we need to stop. So I will give you the example. What happened was I left the hospital job around 2014 and we started with the corporate company. You must have heard of Philips, which is the bulb company. So which used to make also the respiratory devices. So we started a home care division under that and we were 52 therapists and some nurses. So what we did was that we covered around 5,000 patients, and these patients who were coming out of the hospital, they were put on non-invasive ventilation, which is a kind of smaller ventilator,
Sorry to
portable
disturb you,
ventilator.
sir. Sir.
Yeah.
Actually, the next speaker is also have some emergency, so you can take your time, sir.
Okay.
He will
Okay.
not join.
Okay. Okay.
Okay.
So you have to bear with me for another half an hour.
Yes, sir. Yes, sir.
Okay.
Please, sir.
Okay. I am not boring you guys with our topic, but yeah,
No,
yeah.
sir. Such a indeed the very interactive session is going on, sir.
So now coming into basically the role of respiratory field therapies in non-invasive ventilation care. So what we did was in the 2 to 3 years, we enrolled around 5,000 patients and we did the non-invasive ventilation of them in the home only. So 6 to 12 months, they were in under our program, wherein every month they were put on the machine every day and our therapists used to visit them every 15 days. So what was happening is with the help of technology and with the help of healthcare professional as a respiratory physiotherapist, we were able to stop with this 5,000 patients that we enrolled. So with the pulmonary rehabilitation, with the non-invasive home non-invasive ventilation therapy, we were able to stop the hospitalization of around 80% of these patients. So I think even these patients didn't get admitted, and so if they're not getting admitted, they're not going into the ventilator, the mortality chances become less along with the economic benefits. So if you look into the role of respiratory therapist or respiratory physiotherapist in non-invasive ventilation care, so this is the Indian Society of Critical Care Medicine guidelines for non-invasive ventilation in patients with respiratory failure in adult ICU, and it says that your trained ICU staff, like respiratory therapists, nurses, and doctors, should be involved in doing the non-invasive ventilation. So they need to look into basically physiotherapists that are doing non-invasive ventilation. Actually, mainly in the Europe, you can see that physiotherapists combination with the physicians are around 49% of the time it is done by the physiotherapists and the physicians together, right? And 9% of the time it is done by the patient physiotherapist, and 90% of the time, all the patients in non-invasive ventilation are treated by physiotherapists in some way or the other. So see, if here also, you see there, this is the UK NHS job. This thing of October, not October, I think November month that I have put into the slide. So there was a job that basically the physiotherapist should have predominantly they are asking that if you know non-invasive ventilation very well, the job is yours, right? So it has become such important role. So in India also, so there is a huge scope for basically providing non-invasive ventilation for this kind of patient. So this is the training program that we do, and we have trained basically last year we were fortunate to train around 1800 plus physiotherapists on the non-invasive ventilation, respiratory care, and the city. So this was basically the part. So
Sir, you are not audible.
hello, can you hear me
Yes, sir.
now?
Yes, sir. Now audible, sir. Perfect,
Yeah,
sir.
yeah. So now I'll just take you this thing. So anybody from the biomedical engineering basically faculty here? No one?
I think no, sir. I think maybe
So
from
actually,
biomedical.
technology plays. I just wanted to share the technology, how technology has helped us in basically
Yes,
diagnosis and
Prem Shankar is
your.
here, sir. Prem Shankar has raised the hand.
Okay. So I think how basically medical technology or this thing. It is well said that doctors only use technology that it is produced by the good engineers, right? So I think technology helps in the clinicians to treat the patients in a better way, help the patient in diagnosing the patient in a better way. And I think with the technology further developing, with computer science being involved in such a big way now, with the basically your artificial intelligence in terms of large learning networks, etc., will help in further. So there was a recent ERS study which said that the 70% of the time a PFT report is not well interpreted by a chest physician or a respiratory physician, and it can be 90% accuracy can be achieved by the respiratory physician. Accuracy is around 70% in making diagnosis, whereas the AI, if you do a basically large learning network, basically AI, you involve in thousands of PFT reports, and then you give the AI to diagnose it, it is 90% accurate. The accuracy of this are more distinct, improving day by day, and I think that will be further helpful. So when we look into diagnosing some of the basically common diseases, so what we'll look into is look into a specific this thing how to diagnose a obstructive sleep apnea. We have discussed that patients having obstruction and doing the snoring in the night, like this, they are having a problem here, right? Their airways are choking down, and because of the choking down of the airways, what is happening is the patient is not able to sleep well in the night. So how can we diagnose this kind of patient? So we'll just look into what we do for this patient. Is the PPT visible?
Not it's still it is loading. I think the PPT has not opened it.
Yeah.
Sir, there is some question also.
Yeah, I will be most happy to answer
Yes, sir.
the meantime.
Uh, uh, she is asking that what exercise can be done to clear lungs congestion in elderly.
I think I will take it from the up. Which age is more effective, or which age is more
No, sir,
affected
the
by
previous
this?
one, the previous one.
So there is previous one
Hujai,
also. I cannot see that. I think.
oh, okay. Hujaifa, yes.
What
What?
exercises can be done to clear the lung congestion in the elderly? So what
Yes, sir.
for instance, basically, if we look into the lung congestion, if you say, so if we were speaking about basically the secretions in the lung or the phlegm that is stuck in the lung, so that it can be cleared out by simple therapeutic maneuvers like active cycle of breathing technique, which involves your three stages. So what happens is you do in this thing, your ACVT. What we do is the patient has to do three steps. So first is breathing control. So patient does a diaphragmatic breathing, breathing through the nose, breathe out to the mouth, do a diaphragmatic breathing. That is basically when the you take a deep breath with the nose, the stomach should come out, and then breathe out with the nose, around 10 to 15 breaths, followed by thoracic expansion exercises. So this can be done. Then it is followed by basically your autogenic drainage or the FDP, post-activity technique. What the patient does is patient has to take a deep breath, which is more than basically the tidal volume till the inspiratory reserve volume, a deeper breath, and do a half. The patient can be taught putting a mirror or the mobile phone on his phone to put papers on this. So deeper breath, half, right? Then a normal tidal volume breath and a small hug, and then a normal tidal volume breath followed by a cup. So just a normal way of basically mobilizing the secretion, right? So also when to mobilize patients, physiotherapists may help you in doing manual like percussion. So you must have seen lychee patients. What we do is basically low voice, we do the percussion or the vibration to move the secretion up to the upper airways along with the gravity assisted position that is called a posterior drainage position to move the secretions to the upper airways so that the patient can be easily huff and cough out what I have told you earlier. So apart from this, there are also devices in second I'll try to show it to you. So apart from this, we have also some PEP therapy devices or positive expiratory therapy devices. So that can be used for mobilizing the secretion or moving out the secretion of the lungs. So very simple, we have a flutter device here. So you can see, hopefully you guys can see, this is the device here. And this device has a chamber which has a steel ball, right? So what we do is put the steel ball inside this chamber and we connect it to the mouthpiece. And the patient has to be taught to breathe in and breathe out of this. Generally, what he teaches, the patient has to take a normal inspiration followed by an expiration, which is at least 2 to 3 times of the inspiration. So this, so you can see here. So while I'm breathing out, this ball is basically jumping up and down because I'm putting a force on this and the gravity is pulling it down. And because of this oscillations, the airways also get oscillated. It produces as an oscillation of around 30 hertz. And this 30 hertz of oscillation helps in basically mobilizing the secretions from the upper airways, and this secretion can be again taken out with a half and puff. So there are other devices of PEP therapy. These are called positive expiratory pressure therapy devices because this therapy device works against a positive pressure. So patient when he's blowing out, it is giving a positive pressure to the patient in terms of resistance, and because of that, the called airways, which are connected to each other where something called as spores of corn, alveolus to alveolus connection. I think first year, most of the people have learned first year physiology remains same for everyone. So alveoli to alveoli connection, pores of corn, there's a connection. So even if one basically alveolus is collapsed with the secretion, if the air is coming from the other side, it will open up. So this is the same principle. There's the PEP therapy devices. So this is the a cappella device here. It has a magnet resistance here. So we breathe out against this, and this magnet causes an expiration, which further decreases basically puts a vibration of around 25 to 30 hertz, and this helps in mobilizing the secretions. So this devices, many of these devices are textbook devices. The patents are over by the parent company now. So with little innovation, if anybody would be interested, will be definitely help to associate and also doing basically the patents for this own design patents can be taken off for the newer kind of therapy devices. So hopefully I'm able to answer the question. The other question was regarding your. Yeah. So are we, Dr. Gaurav, we are left with people here, or most of people have left?
No, sir. Approximately 170 people has joined, sir.
Okay.
Yes, sir.
So
So Sanjay Kumar Mishra, Dr. Sanjay Kumar Mishra is asking how you will mean a patient with acute hypercapnic respiratory failure from non-invasive ventilation.
so so acute hypercapnic respiratory failure is type 2 respiratory failure wherein your carbon dioxides are increased, right? So generally a patient is put into a non-invasive ventilation, and what happens is the non-invasive ventilation puts generally it is put into a BiPAP device that gives a positive pressure in terms of two pressures, inspiratory and expiratory pressures. So when the patient will take an inspiration, the higher support will come to give the tidal volume, and the pressure when he's expiring out, the pressure doesn't drop to zero, it will maintain so that the upper airways are open and the alveolus don't go into atelectasis or collapse. So now coming into weaning of that kind of patient, what happens is why is the patient having the hypercapnic respiratory failure? So now if I say for COPD, what is the main reason of basically the hypercapnic respiratory failure? So the main reason of hypercapnic respiratory failure is the weak diaphragm. or the dynamic hyperinflation. So as I told you earlier, the diaphragm should have been here, but because it is working continuously against resistance, it has gone weak and it has come down. And because of this, what has happened is it is pulling in less tidal volume, less carbon dioxide is basically going out. And other thing is because of the intrinsic heat, the diaphragm is not going back to its original position. It is stuck here. And there is minus 3 to 4 centimeters of negative pressure that is always inside the lung. And because of this, there is air trapping happening, which is causing emphysema or basically the air trap lung. To remove this, what you have to do is strengthen your diaphragm. So how we do is strengthening of diaphragm. As we do anything is weak. Suppose my hand is weak. What I'll do is I will be taking a dumbbell and doing a resistance training, right? FITT principle, frequency, intensity, type, and time. So here also we use a device that is called as a respiratory muscle trainer, as you can see. So this is a simple device. So it has a pressure calibrated valve here. So there is a pressure calibrated valve here. So suppose I put the resistance at 9 centimeters, or suppose I put the resistance here at 21 centimeters. So here you can see that I have put a resistance of 21 centimeters of resistance. So when I'll be breathing inside this device, so whenever I produce 21 centimeters of pressure, the valve will open. Because now what I'm doing is I'm just doing a dumbbell for my diaphragm muscle. As my diaphragm muscle strength will increase, as my peripheral muscle strength will increase, my breathlessness will come down, my accessory muscles will come down. That means by good pulmonary rehabilitation, the requirement for the non-invasive ventilation will become lesser and lesser, right? So hopefully it answers your question, sir. Yeah, any question, any more question? So Dr. Gaurav, do you have time?
Yes, sir. Yes, sir.
Yeah.
Prem Shankar Gupta has asked, sir, whether X-ray can help in diagnosis of acapnic condition.
So acapnic conditions, or basically if you were talking about acapnic conditions, that means one thing is hypercapnia, where it increased carbon dioxide. But if you are speaking about conditions wherein the carbon dioxide is not high, but the oxygen is low, we try to help the patient with exercises with oxygen therapy to increase the oxygen levels, like in COVID, we did for the type 1 respiratory failure patients. So we do use positioning, prone ventilation, this pulmonary rehabilitation exercises, along with aerobic exercises that help in increasing this. And for obstructive sleep apnea, so I think X-rays are not a good tool to basically make a diagnosis of this kind of patient. So the X-rays do help to us in knowing if it is a emphysema or not, if there is infection or not. But the diagnosis is made by a PFT, the blowing test, where you blow inside a machine to look into the flow volume curves. So that basically helps in making a final diagnosis. Or also
Sir, I think this is, I am muting, sir.
yeah,
I'm
Dr.
muted, sir.
Gaurav, you want to
You
say
can
something?
continue, sir. Yes, sir. Yes.
Sure.
Yes, sir. Yes, sir.
So yeah. So now, so when coming into basically diagnosis of the obstructive disease, we use the PFT. And for acapnic conditions like the obstructive sleep apnea, we use something called as a polysomnography or a sleep study to basically confirm the diagnosis of the sleep apnea. What we do is do a screening of this patient. So what we do during the screening is ask the question, some questions like the Berlin questionnaire, the EPSS or the Epworth sleepiness scale. And the questions are like, how much sleepiness do you have while sitting for around 30 minutes, how much there are chances that you'll go into sleep. If you're watching a TV show, how much chances are there if you will go into sleep, and if you're sitting in a car for 15 minutes. So this kind of questions we ask, and after that we have clinical symptoms, that is daytime sleepiness, headache, etc. So I was fortunate to do the National Sleep Medicine course in 2012 in NIMHANS. So you can see me here somewhere. So what is obstructive sleep apnea is basically, as I told you, is has basically it involves the neck, wherein the neck is getting choked. If you can see here, the neck becomes choked because of the fat deposition, because of the structure of the neck, and because of the age. So it is causing a lot of problem that I've already discussed: cardiovascular, hypertension, etc. So these are the main symptoms: brain fog, anxiety, depression, stroke, low oxygen levels, obesity, impotence, type 2 diabetes, congestive heart failure, high blood pressure, arrhythmias, many of the things can happen. So there are several modifiable and non-modifiable risk factors that contribute to OSA, including the age, gender, genetics, obesity, definitely the smoking, alcohol consumption, sedentary lifestyle, which is already there. So I'm not going to detail. This is basically how much people are affected in the US. So if you look into the uh, basically these are the easy waves of the brain. If you see this shows that how much sleepy you are there. If you look into us basically as adult and basically not as neonate when the baby is born, what happens is we go into the four stages of sleep. There is N1, N2, N3, and REM stage of sleep. So what happens is in non-REM or the N1, N2, N3 stage, we go into basically sleepiness levels. So we slowly go into deeper stage. And then one stage we come to the REM level. There is a random eye movement. That means you go into the dream state of the sleep, right? So what happens is when you go into the non-REM, that is the N1, N2, or the N3 stage of the sleep. So the heart rate slows a little bit, blood pressure decreases a little bit, the airway resistance increases, and because of that, you have the snoring sound also, and the oxygen levels can come down, right? So in REM, what happens is there is increased blood flow to the brain because there is a lot of activity in the brain that is happening, and that's why you see the dreams or nightmares, whatever it is. And the heart rate increases in that cases, and blood pressure can vary a little bit during that, and the airway resistance further increases. So if you have obstruction, the obstruction will increase definitely. So now, what is the function of sleep? Why do we need sleep? Because we have to recover and do the next day's work. Energy conservation, synaptic downscaling, that means the synapses are working throughout the day, and the neuromuscular junctions need some basically relaxation during the night. It slows down a little bit, right? Immune competence has to improve, memory consolidation has to happen, brain growth and repair has to happen, and sleep is the basically most important pillar of us to stay alive, right? So sleep deprivation can cause a lot of problems. So I will give you this thing. I was in a personal emergency from last 2 3 days. So my father-in-law uh, had sleep deprivation for 3 4 days because of hectic work schedule, etc. And we went to a wedding, and in the wedding itself, he had a heart failure. So he is currently in the ICU, doing undergone a basically artificial pacemaker placed today. So this basically shows that how sleep is very important in our life. So if you do not have quality sleep, there can be a lot of problems that can come in. So this is our basically nasopharynx, etc. And if you look into this, so what happens is in the night, this muscles become very these muscles. You can see here, genioglossus muscle, hyo muscle, right? Hypoglossus muscle, etc. These are becoming basically weak, or they're collapsing in the airway so that the desk air comes and you have this obstruction. So what happens is, I'll not go into detail. So what we do is we do a sleep study or a polysomnography study wherein we have basically we involve the level of various levels of sleep study are there, level 1, level 2, level 3. So level 1 studies with a video camera, etc. is done mostly in a hospital, but level 2 studies, till level 2 studies, it can be done at patient's home also. We also get it done for the patients. What we do is use some EEG leads to look into the stages of sleep in the night. Then we also look into the nasal flow to look how much is the obstruction, nasal thermistor or nasal temperature calculators to see if there is stopping of breath in between, because the temperature will be less if there will be no breath coming in, right? Then we have respiratory belts here in the chest, abdomen to feel the respiratory movements. We have the ECG, we have the EOG, electroocologram, to see if the patient is going into the REM, looking into the eye movements of the patient. In EMG, leg EMG, to see the muscle contraction, like, and then overall, looking at all of this, what we do is we do a overnight study wherein we see how much basically problem a patient is having, right? So these are the various apparatus that we use. So that's why I was telling technology plays a major role on this. So you can see, and if you look into the polysomnography report that we do after putting all these wires in the patient's neck, head, eyes, etc., and in the nose, so we take out, we make a polysomnography report where we look every epoch, there is 60 seconds of event that is happening, and we look overnight for around 6 to 7 hours what the patient problem are, and after looking at the patient's problem, what we do is we will get an idea that how much problem actually the patient is having. So this is the report that we generate for the patient. So what we do is we see how much patient has sleep, how many minutes the patient was sleep, how much was the sleep latency, that means going to the bed till going into actual sleep. So here you can see this patient is having 72.8 AHI. That means that means 72 times he's getting partially or fully woken up. Hello, I'll give you a call back. I'm taking a class.
Muting, sir. You can continue, sir.
So what happens is this 72 times this patient is getting partially woken up or woken up in the night. And because of this, what will be the condition of the patient? This patient was having severe daytime sleepiness. The patient was almost admitted to the hospital twice or thrice because of this. And then what we do is we do a titration study, that is put a CPAP machine and slowly increase the pressure to 2 centimeters. And then what happens in the diagnostic part is basically when we do it seriously with a pressure of 12 centimeters of water, when we apply a pressure of 12 centimeters of water with a BiPAP mask, with a nasal mask, etc. So what happens is the patient recovers and his AHI drops to very significantly low levels. So AHI was nearly zero. So here you can see if I can see the histograms or the waveforms. You can see without the therapy, the patient was having these problems. The circulation was going down. There was a lot of obstructions that were coming. This is the saturation here. It was going up to 85. Also, the heart rates going up and down, right? There was significant snoring here, right? Patient even not going to the fourth stage of sleep. So after the therapy with the BiPAP machine, you can see the patient did significantly well and everything becomes corrected. And now the patient is doing very, very well on the device. So this is how technology basically is helping us in treating this patient. So this is one thing that I wanted to discuss. Apart from this, technology in terms of basically tele-reporting, monitoring the patient on basically generating the reports, the patient putting in the symptoms himself, looking into the patient through the telepulmonary rehabilitation helps a lot. So I think this was my presentation for today. I think I was able to share a little gist of what we do for the respiratory care as basically respiratory physiotherapist in the field of respiratory care to decrease the burden of this chronic respiratory disease, which is actually a national problem now because of this huge number of patients being impacted. So if there is any questions, I'll be most happy to welcome all the people in with any of the questions.
Yes, sir. There is a question in the chat box.
Yeah.
Sir, how to relieve the chronic sinus pressure without going surgery?
Sorry, what is the question? Can you repeat, sir?
Yes. How to relieve the chronic sinus pressure without going surgery?
Sinus pacer,
Pressure,
PACER.
pressure, pressure, pressure.
Okay, chronic sinus pressure without. So I think that is more related to the ENT field. So I'll not be an expert to this, but yes, if you do regular exercises, steam, etc., helps something. But I think the ENT expert would be able to give basically a better reply on this. So if there is any other question?
Yes, well said, sir. Sir, respiratory health is a such a critical aspect of the public health, and especially considering the increasing burden of COPD in the worldwide, and it is great to hear that efforts are being made by you in the innovative things to improve the care of the respiratory system and function in the country like India, and you have also an honor of the company. So thank you so much, sir, for the very insightful and valuable talk
I
on
would like to
innovation
thank
and
actually
respiratory
the
care.
university for
Yes, sir.
giving the opportunity. And I think I thank you all the faculty for joining in actually. So I think more people involved in the respiratory care, more will be the smoother journey of the patient. And I think we together, if we work together, will be able to help more of the patients. So I think it is not me now, it is we, how we work together as a we to achieve the larger goal of helping the society. And I'm extremely sorry for the glitches, technical glitches in the beginning. I think that
No, sir.
was a mistake from my end. And I'd like to thank Shagun sir all again for inviting me to this FDP. And I think it was honor part of being the FDP. So thank you so much.
Yes, sir. I think Sagun sir is there. Sagun sir, are you here? Okay. So
Yeah,
Sagun sir is not here, sir, I think.
no problem.
Okay, so sir, on behalf of the organizing committee of this 5-day online international faculty development program, uh, kindly accept the honor of gratitude from the
Thank you.
Galgotia
Thank you.
University family.
Thank you so,
So
thank you so much.
thank you so much, sir.
Thank you so much. It was pleasure interacting with you, Dr. Gaurav, also. And I think thank you so much for helping me during the presentation. Thank you.
Thank you so much, sir.
Thank you all the faculties for joining in.
Yes. So, dear participant, you also have the chance to interact with our eminent speaker. If you have any query still, then you can unmute yourself and ask your query.
Yeah, definitely.
So, some participants are also asking for your email ID, sir.
So yeah, definitely. My email ID is dr. I will write in the chat box for everybody. Just give me a second. So this is my email ID, and also you can find me in Instagram, Sumanta Ghosh _ pulmonary rehabilitation. Also, you can join in our academy, Health Specifics Academy. On our Facebook page. So thank you so much. So if there is any questions, I'll be most happy. Otherwise, we can have a closure for the day. Thank you so much.
Thank you so much, sir. Thank you so much, sir, for accepting our invitation and delivering such an insightful and wonderful, informative and interactive talk. So thank you so much, sir, once again.